Hello everyone, this is Praveen Kumar Tirlangi. Today we'll be discussing about sedation, analgesia and neuromuscular blockade. This is a very important topic in critical care unit. It's very important to understand because this is one of the topic where if you go wrong, if you get it wrong, many bad things are going to happen to the patient. So let us see what we are going to discuss today. Initially, we'll have a conceptual framework. We'll discuss why sedation strategy matters. What are we sedating the patient for? We'll discuss about pharmacology of different sedative, analgesic, and neuromuscular blockade agents. We'll discuss some of the literature on the depth of sedation and is there any difference between the choice of sedation. And we'll discuss about what is analgesia first strategy. We'll discuss about the role of neuromuscular blockades, a few delirium trials, and we'll eventually unify the physiological models and bloodshed stratifications, and we'll understand how to use sedation, analgesia, and neuromuscular blockade in critical care unit. So the core principle in a critical care unit to sedate a patient or give analgesia is not just to give comfort to the patient. Sometimes it is a therapeutic strategy. For example, you have a case of meningitis. For ID physicians, it's one of the common cause of ICU admission, and patient has a raised intracranial pressure. Now, this patient is going to strain a little bit. He can herniate. If this patient is breathing very fast, wash out the CO2. That can lead to CO2 wash out and CNS blood vessel spasm, vasospasm of the CNS vessels, and that can actually increase the risk of neuronal damage. So it is not just to sedate the patient. Now here you are using sedation, most likely a deep sedation, in neurologically critical ill patients to prevent further neuronal injury. At the same time, in patients with severe community acquired pneumonia or ARDS patients who are very hypoxemic, they are going to have a very high respiratory drive. So many of the times you want to give lighter sedation and see if the respiratory drive is coming down, but there will be definitely some patients who are severely hypoxemic and you are not able to control their respiratory drive. Respiratory drive is associated with very high transpulmonary pressures. The patient will be creating a lot of negative pressures in the pleural space. So that will cause actually ventilator induced lung injury. We tend to call it as induced self-inflicted lung injury, just to say that it's because of the patient's respiratory efforts. Now these are the patients who will require a deeper sedation. So most of the times we talk about light sedation whenever is possible, but there is definitely a subgroup of patients where you require a deeper sedation and sometimes you need a neuromuscular blockade. So sedation analgesia is not just for the patient comfort, but it has to be used as a therapeutic strategy in a subset of the patients. That is very important to understand because when we go through the trials and if we don't go through the inclusion and exclusion criteria, many times you take the trial results and put it out of the context in critical care units. That can really can cause harm in the patients whom you are treating. So let us look why the sedation strategy matters. So when we are talking about sedation is like you have to give agent which will cause sedation. If patient is anxious, you have to give anxiolytic, and if patient is in pain, you have to give analgesia. So now the concept overall is analgesia first because people have realized that most of the patients who are agitated on mechanical ventilation not because of they require a sedation, but because they are in some sort of pain. So try to give analgesia, try to address the cause of pain. That is one of the most important thing. I remember when I was a resident, there was a patient of stroke whose Foley's catheter was blocked, and the patient was not able to communicate. He was on mechanical ventilation, and because his Foley's catheter was blocked, the bladder got distended. That was painful, and patient started breathing very fast, and he was sedated for that. But respiratory effort is quite high because that is the only way he's responding to the pain, and there was a lot of CO2 washout, and the ischemic penumbra following stroke has actually increased. So he became neurologically poor because of the blockage of Foley's catheter. So all these things can actually happen in intensive care unit. So it's not about giving analgesia also. Try to find out what could be the cause of pain, and if you know the cause of pain and if you're not able to address the cause of pain, you want to give analgesia, you start with analgesia. Having said that, it doesn't mean that If the patient is anxious and you know the patient is anxious, you are giving an analgesic to treat anxiety. Or this is just imagine a patient coming to outpatient department saying that I'm having anxiety and you giving them a shot of diclofenac. It doesn't work like that. So try to if the patient is fighting with a ventilator, that is one way of putting it, as if it is the mistake of the patient. But if there is a patient ventilator asynchrony, and you are thinking what to do, like is it because of the pain? So try to understand what could be the reason for the pain, or try to give analgesia first before sedating the patient. That is important. But sometimes patients are really anxious. Some patients will have high respiratory drive. Our idea of keeping the saturations 88 to 92% is good enough might not work for some of the patients. Some of the patients will have a lot of respiratory drive at PaO2 of 60, but if you increase the PaO2 of 80, they'll be okay. So even the saturation targets are not something which you have to strictly follow. Some of the patients will have high respiratory drive. That is how you treat. So patients with high respiratory drive, you have to see whether they are very sensitive to PaO2 in the blood, or they are very sensitive to acidosis. So you try to correct that first before really sedating this patient. So analgesia first strategy is what we have to do, but at the same time you cannot use analgesia to treat anxiety and to treat uh, causes other than pain, right? So bedside we really have to do some of the assessment. We have different scales. Most commonly used scale is uh, Richmond's agitation scale, which we call it as RAS, which where you score it from -5 to +4. And most of the times, like -1 to 0 is a sweet spot where patient will be awakening with your commands or quite alert. But these are the patients who are otherwise stable. These are the patients who do not require a very deeper sedation. In patients with a neurological critical illness, or in the patients who requiring a muscle relaxant, you have to ensure that the patient is deeply sedated. You cannot have a patient on muscle relaxant and completely awake, right? At the same time, to assess the pain, there are different scales. Commonly, we use a behavioral pain scale bedside. It's a visual analog scale based on the facial expressions, how the patient is keeping his hands and feet. You can always do it. And if you think that the patient is in pain, you have to increase the analgesia rather than increasing uh, sedation. So this is quite important. So I this is the example I give it to all my residents. So people used to hunt animals with atracurium, so curiariform drugs. So when they used to hunt the animals, animals used to get paralyzed, and but they are very awake. So they are paralyzed, unable to breathe, but completely awake of what is happening to them, and that used to lead to a very sympathetic surge, which will increase the perfusion to all the muscles, and the meat used to become more tasty. So unless you are that animal which was hunted by a hunter in the last birth, and you have become a doctor, please ensure all your patients getting adequate sedation before getting paralyzed. Now, when we are saying adequate sedation here, the adequate sedation here is deep sedation. Probably -4 is what we are talking about in Richmond Almond scale, Richmond agitation scale. So if you are not doing that and patient is awake, he doesn't know that he is not able to move because of some muscle relaxant. So he will be conscious, listening to whatever you are speaking bedside, and but he is not able to move any of his muscles. He is anxious. Now his sympathetic surge will increase. Sympathetic surge can lead to lot of other things. It can cause cardiac arrhythmias. It can cause rupture of the coronary plaque, which is already there, which will increase the risk of MI in these patients. And it is a very torturous situation. You can actually watch a movie called Awake, where the protagonist is on the operation table. He was getting operated for a heart transplant. uh, they forget him to sedate. They give a muscle relaxant, so he's completely awake about what is happening in the surroundings. I would request you to watch this. So what I'm trying to tell you is, if you are in any situation using a neuromuscular blockade, and if you are not deeply sedating the patient, that is the worst thing you can do in a critical care unit. Now when we are talking about deeply sedating the patient, many of the sedatives which we use cannot achieve a RAS of -3 or -4. For example, if you are using Dexmed is for awake sedation, where you wake up the patient will wake up actually. So in such situation, just imagine a patient paralyzed, prone, and is on Dexmed along with atracurium. For every noise he can wake up. So there will be intermittent episodes where the patient is completely aware of what's happening and is not able to move the limbs and is prone. So that can lead to a lot of effects. So most of the times uh, when these patients have this awake sedation, you cannot diagnose it. Many of the times when you go to bedside and ask what is it, people might say that the patient RAS is -3, -4, but once you paralyze the patient, you cannot assess the RAS. So the agitation scale you can only do when the patient is not paralyzed. Now the patient is not able to communicate anyway. So you have to ensure that the patient is in deep sedation before giving that dose of muscle relaxant. Why do we need a muscular neuromuscular blockers in the first place? So it is better always to avoid neuromuscular blockers if you can. But again, there will be a subset of patients where who will be very hemodynamically unstable, and you are giving a good dose of sedation, trying to reach -3, you are reaching it, but still you are not able to knock off the respiratory effort of the patients. And especially in these patients with severe ARDS, if the patient is having very bad respiratory drive, that can actually injure the lungs further. So which is ventilator induced lung injury, or patient self inflicted lung injury, which is what we want to prevent. So there will be a subset of patients who will eventually require muscle relaxants. Try to avoid if possible, but if you are using, use it for shorter duration and ensure that the patient is deeply sedated if you are using muscle relaxant. So unexplained tachycardia or a new onset MI, takotsubo-cardiomyopathy, and tachycardia will can cause sympathetic drive, endothelial dysfunction, and these are the patients. Just imagine this patient getting discharged and remembering all the events in the ICU. It can lead to PTSD and post ICU delirium. Don't give beta blockers or ivabradine if the patient is having tachycardia. Ensure that he is not paralyzed without adequate sedation. So let us dive into different commonly used sedatives and analgesic agents which we use in the intensive care unit. So let us start with midazolam. Midazolam is a benzodiazepine. The mechanism of action is GABA mediated. So this is the commonly used sedative agent in the past, but in modern ICUs we rarely use midazolam as a sedative agent. Depending upon the dose, you can achieve -1 to -4 in a Richmond agitation scale with midazolam. So you can actually achieve whatever the level of sedation you want. However, one of the in many of the trials where midazolam has been compared with propofol or dexmedetomidine, it is found that midazolam is associated with higher rates of delirium and sometimes higher rates of mortality. So this is something which is important. So we try to avoid benzodiazepines as a strategy for sedation in most of the patients, unless the patient is having alcohol withdrawal or drug-induced seizures, where midazolam probably will be a better drug. One of the issue with midazolam is patients who have renal failure, and if you are using midazolam for very long, it can get accumulated, and that can lead to a prolonged sedation. So midazolam you can use, but in modern ICUs we are not using. We are switched to Dexmed or propofol. Let us look into the fentanyl. Fentanyl is not a sedative agent. It is an analgesic agent with little bit of, let us say, the side effect of fentanyl is little bit of sedation. It can cause respiratory depression in high doses. So when you are using fentanyl, you are basically using it to decrease the pain. Patient can get sedated a little bit with fentanyl, but again, so if your target of sedation is deep sedation, if you want to achieve a RAS of -3, -4, you cannot do that with fentanyl. That will require a massive doses of fentanyl, which patient doesn't require. So most of the times you have to combine fentanyl with either midazolam or propofol to achieve a deeper sedation. Both midazolam and propofol will not have analgesic effects. So you want to combine them with analgesia, but you cannot have a patient on fentanyl and a neuromuscular blocker. So fentanyl plus neuromuscular blocker, basically you are not sedating the patient adequately, and it is, you might argue that these patients in ICU are very obtunded. Sometimes even fentanyl will cause a deeper sedation, but it is, how can you ensure when the patient is on fentanyl that patient is not awake any time with neuromuscular blockers. So fentanyl alone along with neuromuscular blockers is a not a right thing to do. The other issue with opioids is This is a short-acting opioid and it will have withdrawal symptoms. So if you are using fentanyl in massive doses for long time, it is a lipophilic agent and it will get accumulated, can cause withdrawal symptoms. So you might have seen some of your patients getting extubated from ICU in the morning, shifted to ward. In ward, patients started developing tachycardia, a lot of sweating, tachypnea, got reintubated, came back to ICU. You must have diagnosed this patient as a probable glottic edema, try to give a dose of steroids, but it is very much possible that it is also an opioid withdrawal, especially in patients with COPD. This is not uncommon. Fentanyl, again, when you give it in a bolus doses, high doses, more than 100 mg usually, it can lead to a chest wall rigidity. Probably this is one of the reasons why you see a lot of fentanyl related deaths in IV drug abusers. So it can cause sudden chest wall rigidity and patient will not be able to breathe. So understand fentanyl is an analgesic agent and has to be used in a combination with other sedative agents if you really want to sedate the patient deeply. How about propofol? Again, propofol, the mechanism is GABA mediated and also NMDA antagonism. So it has a different mechanism of action little bit compared to midazolam, not associated with ICU delirium. Compared to midazolam, the risk of ICU delirium will be lesser with propofol. It can cause little bit of vasoplegia, so difficult to use in patients with septic shock, not a contraindication, but you have to be a little bit careful about what is happening to the arterial pressure. So this is one of the preferred agent in the patients where you want to have a deep sedation. It doesn't have an analgesic effect, which we have discussed. And propofol, you can see the propofol is a white color IV infusion which you keep giving in ICU patients. It's a lot of lipid. So when you're calculating the calorie requirement of the patient, this lipid has to be taken care of. And also when you're infusing propofol, the IV infusion set has to be changed every 12 hours at least. This is very different from what you're doing for antibiotics, which might be using for 1 or 2 days. So very high risk of contamination, and patient should not develop candidemia because of contamination of propofol, right? So one of the advantage of propofol is a very short half-life. So if you stop the propofol, patient will have a rapid offset. So if you want to really assess patient neurologically, you can do that after stopping propofol. So very similar to midazolam with lesser ICU delirium. What about Dexmed? Dexmed is very interesting because it causes something called awake sedation. It will not reduce it preserves the patient's respiratory drive. So you can give Dexmed in a patient in ward if required. Patient will not stop breathing because you are giving an agent. The most interesting thing with Dexmed is cooperative sedation. So if you wake up the patient, patient will wake up, but the moment you stop talking to the patient, patient will go into kind of sleep. It's like a sleep-like state, which is what ideally you want. So it is very easy to achieve a RAS of -1 or 0 with patients on Dexmed. But you have to understand that you cannot use Dexmed to deeply sedate the patient. One of the side effects of Dexmed is patient can have bradycardia and hypotension, especially young patients with a good sympathetic tone. Dexmed can cause bradycardia. So whenever you're giving Dexmed, you have to monitor the heart rate, but you cannot use very high doses of Dexmed to deeply sedate the patient. So you cannot paralyze again patients on Dexmed. So if your patient is prone, paralyzed, and if you see only 2 infusions going on, one is Dexmed, one is atracurium, then patient is in trouble. It's a good anxiolytic and it doesn't have great amnesic effect. So if the ICU, if you are able to manage the patient in intensive care unit only on Dexmed, and then you interview the patient post discharge, patient will be able to recall some of the events which are happening in the intensive care unit. Dexmed is predominantly metabolized by liver, so you have to be a little bit careful about using Dexmed in patients with liver failure again. So Dexmed has been compared with benzodiazepines in few of the studies, and it is found to have a lesser delirium compared to midazolam or lorazepam. What about atracurium? Now, it's a non-depolarizing neuromuscular blocking agent. Not a rocket science, it's a neuromuscular blocker. It's not a sedative. But this is something which people don't understand, especially you have to make sure that your nurses understand it. Because many of the times when you are using neuromuscular blocker, nurses think that it is sedation. So sometimes according to them it is the best sedative agent. So give a shot of etracurium, patient won't be moving. So this is something which people have to understand. Muscle relaxation is, you have to use muscle relaxation very rarely in the sense only when it is required. And when you are using relaxation, it is upon you to ensure that patient is deeply sedated. and uh, and if you use more and more muscle relaxation, the chances of patient developing neuromuscular weakness, critical illness, neuromyopathy will be quite high, especially when you're using steroids also for the patient. So modern ICUs use steroids for septic shock, ARDS, severe community acquired pneumonia, meningitis, and many other times these patients might require neuromuscular agents. Some of them develop hospital acquired infections where they will be using polymyxin. So this combination of polymyxin, neuromuscular blockade, and steroids, many of these patients will end up in tracheostomy. So one of the significant factor for ICU acquired weakness, critical illness, neuromyopathy. So try to avoid whenever you can. Sometimes you do require neuromuscular blockade, especially in patients with early ARDS with a lot of asynchrony. Sometimes in neuromeningitis patients or neurologically critical patients, you might require a neuromuscular agents. But this is not sedative. This is not analgesic. It is just neuromuscular agent. So if we compare this, midazolam and propofol are two agents which you can use to sedate the patient. You can achieve a deeper sedation with this. Fentanyl is analgesic. Some of the patients will have some amount of sedation with fentanyl. Dexmed is awake sedation. It's a alpha 2 agonist. Can cause bradycardia. You can avoid the bolus doses of Dexmed in all patients. You can just start the patients on small dose infusion rather than giving that first shot of Dexmed, which is again associated with a lot of bradycardia. Atracurium is a neuromuscular agent, and this is the most important thing you have to learn. So let us look into the landmark trials, which you will be discussing bedside many of the times, and many of the times you understand that people are taking it out of context. For example, these two trials which we are going to discuss, one is published in NEGM in 2000, the trial of daily sedation interruption. So basically, you have to make the patient awake and ask him to breathe on his own. So daily you can off the sedation for some time, and it is associated with decrease in the number of mechanical ventilation days, ICU length, and fewer complications. Very interesting. But this is for the patients who are already improving, who do not have very high respiratory effort. Not are These are not the patients who are critically ill patients with neurological involvement. So don't do a sedation interruption in a patient with PF ratio of 50 whom you are trying to recruit all the day, and next day morning someone wants to give a sedation free interval, and you have de-recruited whole lung in a half an hour or 1 hour. So this is not for those patients, and you can actually see that the studies have excluded patients with early severe ARDS, patients with alcohol withdrawal, patients with seizures, and patients with raised ICP. So these are the patients who are excluded from this study. Similarly, ABC study. Again, here you are trying to ask them to give a spontaneous awakening trial with spontaneous breathing trial. So basically, you are telling the patient to wake up and breathe. Again, the exclusion criteria is very similar. So these study data results are not to extrapolate to the critically ill patients with a early severe ARDS, or neurological ill patients, or patients with alcohol withdrawal, where patient requires a deeper sedation, patient requires a recruitment, you want to avoid a patient self-inflicted lung injury. And if you give a break of sedation for these patients early in the course, it can lead to a harmful effect. So these studies are mainly for the patients who have already improved, your PF ratios have improved, the FiO2 requirement has come down below 60-50 percentage, and the PEEP requirement is below 10. And this is the patient where you want the patient to bring back from that deeper sedation, and want your patient to breathe on his own. So that is the time probably will be even switching patients to a lighter sedation, something like Dexmed, rather than completely stopping the sedation. So what you can have is rather protocolized sedation rather than giving a spontaneous awakening trial. So you should have clarity on what you are trying to do. Early ARDS probably you want to deeply sedate. Sometimes you want to use neuromuscular blockade, and once the patient is improving, probably you want to take him off propofol or midazolam, whichever you are using, and put the patient on Dexmed. so that the patient can breathe on his own, but he will not be tachypneic, right? So rather than having a sedation free intervals, if you have a protocolized sedation, which is proven again in a trial called sleep trial, there is no difference in the duration of mechanical ventilation. So protocolized light sedation is more important rather than giving daily interruptions. So I think this is the way to move forward rather than giving daily interruptions, which is again misinterpreted, taken out of context, and doing a spontaneous breathing trial in a patient who is requiring a high ventilator requirement is completely out of place. So it is very important to, the whole idea is, do not use neuromuscular blockade if you can. Do not deeply sedate the patient if you can. So rather than deeply sedating the patient, it's important to avoid over sedation. At the same time, it is important to avoid under sedation also. So avoiding over sedation, not necessarily a daily awakening. So probably we can move more towards a protocolized sedations in ICU rather than going for a spontaneous breathing trial in all the patients. This is again very interesting study published in Lancet 2010. It's a small sample size, probably 100 odd patients, 140 patients. And in this again they try to not give any sedation compared to giving sedation, and the study is associated with a decrease in duration of ICU and decrease in duration of mechanical ventilation. This is the study which is quoted so much, and it is taken completely out of the context. You can see actually the patients requiring patients with a high drive states or severe ARDS, all are excluded again. So these are again the patients who are otherwise doing okay, and if not giving sedation for this patient. So basically, patients who require sedation were excluded, and this is not from a medical issue. Most of the patients are from post-surgical or trauma patients. So, and you give a SOS morphine or bolus of midazolam if required. So this is interesting because after this, in early 2010 and onwards, you have seen patients being restrained, some of them being tied to the bed, because people don't want to use sedation, because there is a trial which shows that not using sedation is associated with a decrease in duration of mechanical. So this is an absolutely wrong thing to do. Again, when you're reading a randomized controlled trial, even though it is published in a big journal, you have to understand that what is the population where you can apply the results of the study. So if, for example, if the patient is improving and a patient is not requiring deeper sedation, and you're looking at the patient is otherwise very comfortable without any analgesia, you can obviously avoid any form of sedation if possible. But that's a very small subset of the patients. You cannot extrapolate such results in patients who are in severe ARDS, requiring a very high PEEP, and the driving pressures are quite high. So these are not the patients where you can avoid sedation. So please don't take the trial results out of the context. Now let us compare different sedative agents. We have discussed about it. Dexmed is head-to-head compared with lorazepam and midazolam. Men's trial is dexmed against lorazepam, found to decrease the delirium prevalence compared to uh, lorazepam. Again, found to decrease the delirium rates and duration of mechanical ventilation compared to midazolam. But dexmed again had a little bit of bradycardia. So dexmed will actually cause bradycardia if you given in bolus doses. So if you can avoid that bolus dose, that will be better. But again, patients with a lot of autonomic tone, like young patients, are more likely to develop dexmed-induced bradycardia rather than elderly. So again, SEDCOM trial is a trial which compared dexmed with midazolam with very similar results. So we stop, even propofol is head-to-head compared with midazolam in many trials, and it is now accepted that benzodiazepines are actually associated with a higher risk of ICU delirium, which is less common with dexmed and propofol. So dexmed and propofol are better agents. Probably dexmed is something which we'll be using in patients who are already improving, where you don't require a deeper sedation, and propofol will be using for the patients who require deeper sedation. So again, Prodex is a trial which compared dexmed with propofol. Medex is a trial which compared midazolam with propofol. Both have a very similar outcomes. Benzodiazepines are associated with a higher risk of ICU delirium. So people started thinking that, how about bringing the dexmed early on? Because dexmed is something which is decreasing the sympathetic tone, and sympathetic tone is one of the reason where patients develop endotheliopathy. It's called SHINE, shock-induced endotheliopathy. More the autonomic stimulation, more likely to have endothelial damage. So if you bring the dexmed early into the course of the patient, like patient requires a deeper sedation, so use combination of propofol with dexmed rather than using propofol. So again, it is studied early dexmed in combination in patients. Many of those patients are in shock also. So whether it is associated with benefit, that it was not shown to have any mortality benefit. And again, dexmed is associated with bradycardia. This can be sometimes harmful in patients with septic shock. So basically, in septic shock, excessive heart rate is also harmful. So if your patient is having very high heart rate, probably you can use dexmed, but dexmed decreases the heart rate. That is what you have to understand. So in septic shock, the tachycardia can be just compensatory. So in a patient who is not resuscitated properly, if you try to come down on heart rate, then it can be a problem. Sometimes you hear this crazy stuff like patient is on dexmed and fentanyl and atracurium, still the patient's heart rate is 140. The patient's heart rate is 140 because he is awake and you have paralyzed him. So such things should not happen. How about analgesia first strategy? We discussed about it because most of the times the patients who is agitated, they are agitated because of the pain. Pain can increase the respiratory dive, which can cause asynchrony or dysynchronia in the mechanical ventilation. So what you do is you sedate the patients again, and sedation is not going to bring down the pain. So the patients will require more and more sedation is associated with eventually higher risk of tracheostomy, more ventilator days, and associated with more of incidence of ICU delirium. We have discussed about the neuromuscular blockade. Try to avoid it. We keep telling try to avoid neuromuscular blockade. So there are two important trials which are published. One is Accurary study, which is published in 2008 or 9, and then is a Rose study, which is published approximately a decade after. So in Accurary study, use of neuromuscular blockade in ARDS patients who are very severe with a PF ratios of less than 150. If it is used for first 48 hours, it is associated with a mortality benefit. Absolute reduction in mortality is 9% in the study, and ventilator free days are more and less incidence of pneumothorax. But at that point of time, the standard of care was different. So at the time when Accurary study was going on, many of these patients were given a very high tidal volume ventilation, which is not a standard of care now. The Procever trial was not yet published, so many of these patients were not prone also. And so basically, you have compared a arm with very deep sedation and neuromuscular blockade versus a patient with very deep sedation. Not all patients requires deep sedation also, and we know that deep sedation is associated with adverse outcomes. So in Accurate trial, if you are using probably in a population where people are using a high tidal volume, deeply sedating every patient, not doing proning, in such a population, it was shown to have a mortality benefit. Whether this study data is applicable after a decade is what we have seen in Rosie trial. In Rosie trial, it is shown that there is no mortality benefit using neuromuscular blockade, and it was stopped early because of the futility. But now you can argue that then why are we using neuromuscular blockade in some patients? So basically, in Rosie trial, if you look into the exclusion criteria, a very significant number of patients were on neuromuscular blockade. So approximately 600 odd patients, physicians they use neuromuscular blockade and they cannot be recruited in the trial. So basically, the population which required neuromuscular blockade got excluded in this study. So finally, it will not going to change your how you manage the patient. So basically, you try to avoid deep sedation, try to give lighter sedation for your patients. But if required, you will have to give deeper sedation. And in a small percentage of population, even deeper sedation will not be enough to decrease that respiratory drive. You might have to use neuromuscular blockade. So small percentage of patient requires neuromuscular blockade, and if the patient requires neuromuscular blockade, make sure that the patients are deeply sedated. Don't give a sedation free interval on neuromuscular blockade. This is another thing which can sometimes happen. Patient is on atracurium, but the sedative agent is stopped to assess whether the patient is breathing spontaneously on day 2 of severe ARDS. Now, So there will be definitely a small population where you have to use a neuromuscular blocking agents. So these are the difference between Accuray trial and Rose trial, right? What about delirium? So why not give a agent like haloperidol or ziprasidone to prevent delirium in this patient? So in intensive care unit, all the clinical syndromes are multifactorial. So it is not that easy. The ICU delirium is not because patient became psychotic with excessive dopamine suddenly. It is a neuroinflammatory state. You see, if you understand the kynurenine pathway with a high interferon gamma, patient will have accumulated quinolinic acid in the brain. You are giving a lot of beta lactams, which again increase the risk of neurotoxicity. So the delirium in ICU is multifactorial. You cannot just give one medication in the night to prevent delirium. This is important thing to understand. So in this mild mind trial, and there are a few other studies which failed to show any benefit using daily haloperidol ziprasidone in the night to prevent delirium. So how do we manage this patient? So this is an again ABCDEF bundle study which has shown that it is associated with decrease in delirium, decrease in physical restraints. Using physical restraints in ICU should be banned unless there is a extremely good reason to do so, and it's associated with mobility. So what they have done, they are doing they are assessing, preventing, and managing pain. They are giving both spontaneous breathing trials and sedation-free intervals, and they are very clear about what analgesia and sedation they are using. So everything is protocolized. Delirium assessment where you use ICU CAMS criteria, but again you cannot do a ICU CAM in a patient who is paralyzed. So many times you see a nursing chart with ICU CAM and patient is completely paralyzed. That should not happen, right? And early mobility and exercise, these are and family engagement and empowerment, so these are very important things in intensive care unit. Many of the times the patients do not understand what is happening to them. So if the patient is awake, try to communicate with the patient, try to engage with the family, tell them they are going to be okay, tell them the whatever the effects they are having at that point of time are because of the medication. And if they are tracheostomies, tell them that it is not a permanent tracheostomy, it can be closed after 2 or 3 weeks. uh, Otherwise this will cause a lot of anxiety and agitation in these patients. This ABCD bundle is what we have to follow. So how are we going to manage sedation, analgesia, and muscle relaxation in bedside? So we always talk about the problems of oversedation, which are true. If you are sedating the patient, the patient is more likely to get a ICU acquired weakness, diaphragmatic dysfunction. Patient's mechanical ventilation duration might be increased, and mortality can be increased. But again, at the same time, under sedation is also a problem in a subset of patients who are having very high ventilatory drive, who are having alcohol withdrawal, who are having seizures, and who are having neurological illness, who are landed up in critical care. So these patients probably you have to give a deeper sedation. So you have to protocolize the sedation in ICU, sedation analgesia. So in early patients with severe ARDS where patient requires high drive, you use a deeper sedation, use muscle relaxants if possible. But once the patient has stabilized, you try to attain a RASH target of -2 to 0, rather than using propofol or midazolam. Probably you can use dexmed at this point of time. These are the patients where you can actually give a spontaneous breathing trial or sedation free interval, and try to give analgesia more than sedation. Focus should be more on analgesia at this point of time. Assess the patient for ICU delirium by using CAM ICU scores, and the patients once recovering, you try to taper down the analgesia and sedation. So many other times you have to treat a sedation analgesia like like a pressure. So you have to slowly come down rather than just stopping it suddenly, especially opioids. Fentanyl can have a withdrawal effects if you suddenly stop them. So that is how we have to treat the patients in ICU, and these are the very important trials which are completely taken out of the context. We keep seeing people arguing against neuromuscular blockades for every patient because there is a Roche trial which says that neuromuscular blockage is not associated with any benefit. But again, you have to see that they are not able to include 600 to 700 patients because physicians decided that this patient requires a neuromuscular blockade. You keep seeing in intensive care units patients getting spontaneous breathing trials on day 2 of ARDS. That should not happen again. The spontaneous breathing trial or sedation-free trials are for the patients who are already improving. Um, Dexmed, it was costly previously. Now the cost of Dexmed is coming down, so we are using Dexmed more commonly in intensive care units. Try to avoid the boluses of Dexmed. Uh, Infusion, IV infusion should be enough. Boluses are associated with bradycardia. Thank you very much.